Greetings, everyone. Thank you for being here with us today. My name is Agnes, and I'm the chair for the Center for Gender Equity at University of Global Health Equity. It's a great pleasure to welcome a great panel of speakers on this important topic. But before doing so, let me introduce a bit about the Center for Gender Equity and what we do here at UGH. The Center for Gender Equity was established in 2020 and has been working towards contributing to gender equity and diversity through UGH's 4 pillars, namely our education programs, our research activities, organizational development, and community and student engagement activities. So in the efforts to ensure gender equity and diversity, we recognized the importance of doing a gender and diversity audit. And this was executed after developing gender and diversity study tools, surveys, interviews, and policy and document reviews were undertaken. And this process was really important in creating awareness among our students and staff. Right now, the gender and diversity audit is completed, and the results are going to be useful for designing gender and diversity sensitive activities at UGH. So we are really on track and hoping that this process and lesson can be shared with others. I would not say a lot on this, but wanted to outline that the gender audit has been a very participatory process. We looked at organizational plans, processes, policies, and even the organizational culture. On the other hand, diversity assessment looks into how sensitive an organization is to the needs of different groups, minorities, people with disabilities, gender minorities, racial minorities, ethnic groups, and so on. And here we want to stress that the definition of a minority is not differs from place to place. So we have to work on identifying which groups are considered as minorities in a given context. So with the audits that we have prepared and the lessons that we have from this study, we are happy to say that we are in track and we are in a position to provide consultancy services or technical support to those who are interested in undertaking a gender and diversity audit, and we welcome any further communications on that. So thank you for your attention, and we will proceed to the next program. Yeah. So without further ado, let me introduce our speakers to this panel. Professor Agnes Pinagwajo, who's the chair of this panel, currently resides in Rwanda and is the vice chancellor and co-founder of the University of Global Health Equity. She previously worked as the executive secretary of Rwanda's National AIDS Control Commission, as permanent secretary of the Ministry of Health, and as the Minister of Health. She serves as a senior advisor to the Director General of the WHO, is a senior lecturer at Harvard Medical School and adjunct clinical professor at Dartmouth. She has published over 210 among the 100 most influential African women for 2020. Our first speaker, Dr. Talia Abrahamsen, is a social scientist focusing on racism, reconciliation, intercultural understanding, and anti-racism. Her research focuses on everyday reconciliation and racism in the education system, including from the perspectives of young children, and designing and evaluating approaches to address institutional racism in a range of sectors. She has presented at national and international conferences and has been a visiting fellow at Victoria University, Wellington, and Queen's University, Belfast. She has over 20 years experience working in social development and social policy in racially divided communities in both Australia and in Israel. Talia has received numerous awards, including the John Ura Award for her contributions to Australian public policy and research. She undertook her PhD as the Sir Roland Wilson Scholar and currently maintains a role in both the Australian Public Service as a researcher in residence and at the Center for Aboriginal Economic Policy Research at the Australian National University. Welcome, Professor Dr. Talia. Our second speaker, Bishop John Rusayana, has a Master of Arts in Religion from Trinity Episcopal School for Ministry in Cambridge, Pennsylvania. He is one of Rwanda's most effective leaders, an evangelist, spiritual and social entrepreneur. He has contributed to the infrastructural development in Shira Diocese and has founded prominent schools, hospitals, and health centers. He is the chairman of the National Unity and Reconciliation Commission from 2010. His tireless work is in finding peace, forgiveness, reconciliation, and other initiatives on reconciliation in denominational church and community development. He is the author of The Bishop of Rwanda and the Jesus Hope for the Nations, a biography. He received awards for Climate of Excellence in Leadership and that of William Wilberforce Award in 2009. Welcome to the panel, Bishop John. Our third speaker, Dr. Sylvia Carpagam, is a public health doctor and researcher based in India. She studied at St. John's Medical College and holds an MD in community medicine. Her focus of work is mainly on the social determinants of health. Dr. Carpagam is also involved in the National Family Health Survey in Karnataka and documented the exploitative working condition of field researchers as well as gaps in data collection. Her interests include nutrition, caste, gender, education, livelihood, shelters, and so on. She is part of the Right to Food and Right to Health campaigns in India. She is also the coordinator for the Indian chapter of the campaign against racism. Dr. Sylvia believes that it's vital to have representation from marginalized communities at all levels of the healthcare system as one way of making the health system more responsive to social issues and to combat discrimination. Furthermore, Dr. Carpagam interests include global public health, health systems and government and civil society, and she holds a certificate of community medicine at Rajiv Gandhi University of Health Sciences. Welcome to the panel, Dr. Raja. Our final speaker is Dr. Michelle Morse. Dr. Michelle Morse serves as the Deputy Commissioner for the Center for Health Equity and Community Wellness and is the inaugural Chief Medical Officer at the NYC Department of Health and Mental Hygiene. Dr. Morse is responsible for leading the agency's work and in bridging public health and healthcare to reduce health inequalities, guiding the center's place-based and cross-cutting health equity programs, and serving as a key liaison to clinicians and clinical leaders across New York City. Dr. Morse is an internal medicine and public health doctor who works to achieve health equity through global solidarity, social medicine, and anti-racism education and activism. She's a general internal medicine physician, part-time hospitalist at Kings County Hospital, co-founder of Equal Health, and an assistant professor at Harvard Medical School. Dr. Morse has worked with several Equal Health partners to found the Social Medicine Consortium. She serves as Deputy Chief Medical Officer of Partners in Health and now serves as on the board of directors of PH. In 2018, Dr. Morse was awarded a Soros Equality Fellowship to launch Equal Health and the Social Medicine Consortium's global campaign against racism. From September 2019 to January 2021, she served as a Robert Wood Johnson Health Policy Fellow in Washington, D.C., and worked with the Ways and Means Committee, majority staff in the House of Representatives. It's a great pleasure to welcome you all. And now I'll give the floor to the chair of the panel, the webinar, Professor Agnes, who will be setting the stage for today's webinar. Thank you.
Thank you, Tion, for this great introduction. As I know that you have registered and joined from around the world to participate to this webinar, I wish you all good afternoon, good evening, or good morning, whatever place you are joining from. And you can see that we have here wonderful speakers coming from several continents: Africa, Oceania, America, and Asia. And I'm delighted to welcome everyone to this timely webinar and thank our wonderful panelists for joining us today. And please note that we have a live captioning for accessibility to people who cannot hear, so that for all you can fully understand our webinar today. So the webinar will feature different global experts, as Sion have explained to you, who will discuss the impact and origin of racial bias, the stigmatization and the marginalization of groups, as well as the caste-based discrimination, and highlight how this has been exacerbated during the COVID-19 pandemic. This month, the United Nations commemorate the International Day for Elimination of Racial Discrimination. But racial discrimination is any intolerance or inequity against any individual based on their color of skin or origin. However, we must note that there is no scientific basis for human racial classification, because race is simply a social construct. And maybe we should start rejecting that in block and stop talking about race that define only identities based on physical characteristic, not on biology. According to the US Census Bureau, today, racial categories generally reflect social definition in the US society and are not attempt to define race biologically, anthropologically, or genetically. So race is a social construct and was conceived, why? It was conceived to justify European conquest of people who had different skin tones and to dehumanize them through imperialism and ultimately steal their land and their riches from America, Oceania, Asia, or Africa. This has gone on for over 400 years. And today, we still live the consequences of the colonial and imperialist movement of Europe. Racial discrimination is ever more evident today with COVID-19 pandemic, which has exacerbated, not created, inequities, such as the lack of access to quality care or lower access to COVID vaccine. We have seen discrimination as really a pandemic in the pandemic. With the murder of George Floyd, the world has wake up. It has fueled the world with global awareness about injustice that were there for more than 100 years, or 400 years, and racial discrimination that minorities face around the world. Many people around the world are really also fighting racism with the Black Lives Matter movement that has gone all over the world after the murder of George Floyd. So we need to dig into our history to understand how race was used as a tool to justify structural violence for domination and greed. And by the 18th century, race was widely used for sorting and ranking people in the English colony. Europeans who saw themselves as free people conquered the land of the Native American, using the African as slaves. And this hierarchy continued to have consequences today. Racial discrimination leads to the perpetuation of inequities by institutions in all sectors, such but not limited to the health, public safety, residential, and media industries. We will discuss those things from all continents. Racial discrimination is institutionalized through laws and justified to fake science, further perpetuating the exclusion of marginalized people, of many minority groups. For example, indigenous in prison population have been shown in Australia that has increased disproportionately the incarceration rate of native people of Australia. Furthermore, although the Aboriginal people are in Torres Strait Islander adult in Australia make up around 2% of the national population, They constitute 27% of the national population in prison. Moreover, there is a strong correlation between the bias, structural racism, and social determinant of health, which all play a role in fostering health inequities. Because of this, the impact of racial discrimination and bias ranges from immediate to long-term physical, mental, and emotional consequences, and even death, with what happened to the Native Americans, or also to the Tutsi in Rwanda. During COVID, it has also been found that healthcare workers from minorities communities in the US and UK have a higher COVID infection and mortality rate compared to their white counterparts. So I cannot go without saying that the pandemic fueled anti-Asian racial discrimination. We have seen examples recently. These inequities increased during the pandemic and give more significance to all what is created, and we need a call to action to promote institutional change. And this webinar will provide the opportunity to raise awareness about the situation in all continents. And in this panel, we aim to offer the opportunity to take lessons from evidence of the impact of racial discrimination, preventive practice and policies, and in fighting racial bias. The discussion will explore from a global, regional, and local perspective what institution, private sector, government, and civil society can do to eliminate racial discrimination. So I'm going to give the floor to our first speaker. Join me to welcome Dr. Talia. Talia will sharing with us today the early acquisition of racism and its implication on First Nation and other non-Anglo children. Talia, the floor is yours.
Thank you for such a warm introduction, and it's an incredible privilege to be on this such esteemed panel. In Australia, we acknowledge country, and I'd like to take a moment just to acknowledge that I am on Ngunnawal country and pay my respects to this country and the narratives and custodians who've cared for this country for well over 21,000 years, but across Australia for 65,000 years. And that's many, many years and generations of intercultural understanding practices and negotiations and diplomacy. And the narratives of this country at the moment, certainly for the past 230 years, are ones of racial violence. So I'd also like to extend just respect and acknowledgement to those who are presenting here today and honour your narratives and stories in this space of what we're talking here today around the elimination of racial discrimination. So I could speak about the prevalence or the impact on children and young people in relation to racial discrimination and racial violence. And certainly we've seen an increase also in Australia, particularly last year and going into this year in relation to COVID and Black Lives Matters. But what I wanted to do today is to focus specifically on some of the messages children are receiving in Australia, particularly in schools. And we can couch that in relation to the importance of understanding the early acquisition of stereotypes and prejudice and how that informs and influences long-standing and latent effects into adulthood about intercultural relations. So it's really important to understand these messages. So in Australia, as soon as children walk in through the school gates, they're constantly exposed to messages around diversity, multiculturalism, reconciliation between Australia's First People, and non-Indigenous Australians and the state. And often these approaches to intercultural understanding are very much around celebrating culture, celebrating the other. And often what happens is a complete silencing of race and racism. And children receive these messages in a whole range of different ways, whether it's pedagogical practices or the beliefs of the teachers who are delivering those messages. They're also in symbols, whether there are flags, particular flags at school or in the library, what kind of books are available, or the posters on the wall. But they're also delivered through celebrations and ceremonies. And often these ceremonies can be daily or they could be annual. And just the past week in Australia, we would have had in many, many schools Harmony Day. And this is how majority of schools would celebrate and acknowledge the International Day of the Elimination of Racism. And so we can see this ongoing narrative of celebrating cultural diversity in place of actually understanding Australia's history and contemporary experiences around race and racism. So why that's so important is that children themselves are actually engaged in conversations about racism. And a study that I was involved in 2 primary schools here on Ngunnawal country, an urban setting, very multicultural schools, was children do know about racism. They talk about it as being a black and a white problem, but they also focus on it being very much an individual pathology, so that it's around not being kind. There's a distinct hierarchy they express, and including those who have come recently to Australia and may have themselves experienced racism, that First Nations peoples are certainly on the bottom rung. There's an aversion to being called racist, and an unawareness of the privileging and normalisation of white culture, which is unsurprising given that we would reflect this in the adult population as well. The other important aspect is that it's anachronistically positioned. So it's positioned in the past. We've passed a racialised or racist country. Those acts happened in the past. And certainly from a children's perspectives, they don't feel that they should be talking about it. Teachers tell them not to talk about it. So there's solutions for how we could be addressing a much more racially literate anti-racism approach to racism and the messages children are receiving. We have to engage directly with the assumptions, and one of the strongest assumptions is that children don't see race and that children themselves are experiencing childhood in a singular way. And so there's not the narratives of different experiences of how race actually interacts with a childhood or with childhood. We also need to ensure that any evaluations are picking up some of those nuances of different communities and different experiences of childhood and racism. And in keeping with the theme of this year, I think we certainly are seeing the strength in children and young people starting to challenge, or not just starting, but challenging the status quo around not talking about race and racism, where we actually see not only First Nations peoples and young people and children challenging the narratives, but also an increasing non-Indigenous children and young people, as well as other cultures starting to challenge these narratives. Thank you.
Thank you, Talia, for an insightful presentation. When I say in the beginning that race has no biological or scientific grounds, that's true that not talking about the discrimination based on racism and be silent on that help perpetuating it. And the example of children that are exposed to message and activities that transfer passively the societal ranking that perpetuating the native group, the native people of Australia, being at the bottom of the social ranking is a question we have to ask. How talking about discrimination of minorities while educating our children not to be. Thank you. Our second panelist is Bishop John Buchanan. He will discuss the lesson learned from Rwanda and the national journey to achieve unity post-1994 genocide against the Tutsi. The floor is yours. Votre grâce.
Thank you, Professor. I just want to share that Rwanda, like any other African countries, was affected by the resolutions of Berlin and was broken by the division, which took part, a greater part of the Rwandan geographical area, taken to DRC and the southern Uganda, and a little bit of it to Tanzania and small bits to Burundi. As though that was not enough, Rwanda was divided according to the divide and rule policy of the colonials, and they turned social classes into ethnic groups, and they introduced the identity cards showing the Hutu, Tutsi as the tribes of Rwanda. As though that would not have hurt Rwanda enough, they taught this in schools for many decades, and this was turned into political policy and a practice. And hence, they persecuted the ruling class in Rwanda, which had requested for independence in 1959. And they burnt their homes and killed a number of them and sent a huge influx of refugees in foreign countries. At the climax of this persecution and division introduced by colonials but practiced by the Rwandans, more than 1 million people were killed in the climax of the genocide in 1994, where many people, over 1,364,000 persons were killed. But at this point, the Rwandan men and the women chose to stop the drain of the human lives, economic resources, and the social fabric of Rwanda, and chose to stop the genocide. And by the time they stopped the genocide, they arrested over 120 persons on a rampage, killing people on the hills of Rwanda. Despite that, they established a policy of no revenge, instead established the restorative justice, and the Gacaca courts settled about 1,900,000 cases in the process. And they also repatriated over 4 million refugees who had run away from the country in 1959 and those of 1994. Rwanda established unity and reconciliation and started healing the trauma of the people from both the perpetrators and survivors of the genocide. And they also established good governance policy and the board of good governance in the country, which gives the Rwandese equal rights and equal opportunities in the restoration of Rwanda and the life in practice. Rwanda established a new constitution to answer the circumstances, guide and protect the state. The Rwandan leadership is the backbone of this current transformation, which encourages each Rwandan to take part in the newness of their nation. Rwanda is a member of the global village. Hence, Rwanda is open to relate well to the whole, but not exploited and dictated on as it were. Rwandan economy has grown steadily into these new policies of the country, and the Rwandan security has come firm and encourages people in their social development. Unity and reconciliation of the Rwandan people is the source of energy for development. And good governance creates a sense of national ownership. Citizens are responsible to shape their destiny. If racism was just an attitude, one would be tempted to ignore it, but its a practice or practices should be resisted by all means. And those who practice racism exploit their victims by physical crimes and exploitative policies at different levels. So it should be exposed and resisted. Rwanda chose to take care of its sovereignty, destiny, and dignity. Rwanda chose to fight against corruption, but be accountable to the nation and to the people. Unity is essential in all aspects of the life of Rwanda. I thank you all. I will be happy to answer any question.
Thank you, Bishop Ruchihana. And I'm sure the question will come. Thank you for sharing with us the journey to unity in Rwanda and how racial division is a social construct. Rwanda is a great example of that. And also ethnicity is a social construct in our country, which what you have reported show that those actions, those social constructs go up to kill 1 million people and destroy a country. You have highlighted the importance of governance in restoring harmony, and this is not enough highlight. And also the example of ownership of the problem and the refusal to continue to define ourselves as from different race or different ethnicity. And this is a totally other way to take the problem. We just say, we are not from different race, we are not from different ethnic, and we go from there. So there is a lot of debate here. Allow me to welcome our next panelist, Dr. Sylvia. Dr. Sylvia is going to discuss the caste as a social determinant of health. Dr. Sylvia, the floor is yours.
To thank the University of Global Health Equity and Professor Agnes for this session. I think it's very useful and very important. Firstly, I'd like to start off with a little background of the health situation in India even before the lockdown. As you can see, we have a whole lot of statistics in terms of nutrition indicators. It's a cause for concern. In terms of maternal and infant and under 5 mortality rates, it's still a long way from reaching the expected standards. We have high levels of anemia. And as you can see, the screening for most malignancies is pretty low in India. We also have both communicable as well as non-communicable diseases. The healthcare system is very centralized, corporatized, privatized kind of a model. And there's most of the public health funds are routed into the private healthcare facilities. I'd like to also mention that most of these indicators are worse for some of the traditionally marginalized communities in India. We have the scheduled castes and the scheduled tribes. The scheduled castes are at the outside of the hierarchical caste system. And most of the people who are in decision making are those who come from the oppressor communities who are actually in the minority, but in terms of capture of resource and decision making, they are in the majority. And the impact, the adverse health impacts are felt on these marginalized communities. And during the COVID pandemic and the subsequent lockdown, we had a series of outcomes, most of them unexpected and unplanned, at least by the government. I think many of us expected these outcomes because the lockdown itself was very aggressive and there was very little support by the government in terms of the impact of the lockdown on a lot of people. So we had loss of livelihood, we had people losing their incomes, and people lost access to a lot of the social security schemes around pensions, around livelihood, and also around food security. We saw large-scale conversion of even the pre-existing large secondary, tertiary, and super specialty public health facilities into secondary COVID facilities. And this had a lot of adverse impact on the non-COVID diseases like tuberculosis, HIV, non-communicable diseases, a lot of infectious diseases, and vaccine preventable diseases. And we expect to see a surge in these diseases and also multi-drug resistance for many of these conditions. We expect a rise in malnutrition related mortality as well as morbidity. And we also, I think, even though it was already pre-existing during the pandemic and lockdown, we saw that the frontline workers who are mostly from these oppressed communities, like those who are working as cleaning staff and sanitation workers, people working in mortuaries, in burial grounds, I think a lot of them were faced labor law violations, and they were exposed to occupational hazards. And many of the social determinants of health unraveled much more during the COVID pandemic. We saw that I think people, because of loss of income and because of loss of livelihood and because of large-scale migration of people back, I mean, reverse migration, it affected a lot of their health outcomes. And some of the worst things that we saw during this pandemic and lockdown was growing Islamophobia and growing discrimination. Also, I think this government used this opportunity to pass several anti-people laws. I think many of you must have heard of the farmers' protests that are going on for the last several months. We also have arrests of people who are dissenting and challenging the government, pushing off public resources into private healthcare facilities. Again, there's a lot of involvement of multinationals in government decision making, which is a cause for concern. And clearly, there's a disconnect of the decision makers with the large group of people within the country. Some of the best practices we saw that civil society and ordinary people came out in large numbers to support those who've been affected by the COVID pandemic. And I think this is a good lesson for us on how solidarities can be built. And we also saw, I think, a growing awareness of the importance of both the social determinants of health as well as a public healthcare system. And some of the solutions, I think, would be common across presentations, that is to have a global oversight on multinationals, to have more use of local resources for local needs rather than grand private or market-friendly decisions that are disconnected with ordinary people. And also, I think, to foreground social determinants of health and as well as inclusion of diversity within medical education and healthcare. And definitely the last point, which is investment into public healthcare and a global demand for better public healthcare systems. So I'd like to end there. Thank you so much.
Thank you, Sylvia, for this very informative presentation showing how the lockdown has exacerbated racism in India. And again, how crucial is the role of good governance when it's lacking its worst, and the role of awareness and solidarity. I want to remind everybody that we have a live captioning, and it's a matter to click on the bottom near the Q&A question. There is a button you can click there to have access to the live captioning. Our last but not least panelist is Dr. Michelle Morse, a dear friend also, who is joining us from her workplace in the United States. Michelle, the floor is yours, and please share with us the anti-racism practice and tell us how far can we go. The floor is yours, Michelle.
Hi, everyone. My name is Michelle Morse. I'm the Chief Medical Officer and Deputy Commissioner for the Center for Health Equity and Community Wellness at the New York City Public Health Department, and looking forward to the conversation today on this special United Nations designated day against discrimination. And I'm going to be talking a little bit about declaring racism a public health crisis. How far can we go? I think it's important in any conversation about racism to start with definitions, recognizing that the way racism and systems of racism manifest around the world is very different in different contexts, but there are many, many shared threads. The definition of racism that I'm going to be using for the conversation today is a definition from Dr. Kamara Jones. Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, which unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society. I think this is a very thorough definition and really gets at the fact that racism, again, is a system, it's not a person. Race, the way that I'm going to be using the definition of race today, is that race is a socially and politically constructed way of grouping people based on how they look, that has no genetic or scientific basis. And I know that we're going to get into this in the conversation and Q&A today, but that is particularly important because in the United States, at least, there is still a legacy of racist medicine that shapes how we actually use race in clinical care to this very day in 2021. And we do it in ways, unfortunately, that likely worsens racial and ethnic inequities in health outcomes. So I know we'll talk more about that. I think this snapshot of the current state of racism in the United States is very helpful for our conversation and for setting up the conversation today. These maps specifically compare Black and white outcomes, but as many of you know, in the United States, our systems of racism certainly oppress, marginalize, and exclude Black, Indigenous, and people of color, not just Black people, but this snapshot is specifically, again, for Black-white comparison. This was published last June, on Juneteenth in 2020, just weeks after the murder of George Floyd, by Dr. Keeanga-Yamahtta Taylor, who has written extensively about how racism and social oppression and structural violence operate here in the United States. But I want to highlight specifically the graph on the lower right corner. What you see in all of these graphs is that the trends from the 1960s until the current day may in some ways be positive in terms of some improvements for Black folks, but what you see in every single graph is that the Black-white gap has not narrowed over the course of the past several decades, despite the huge gains in the civil rights movement and massive nationwide struggle against racism across this country. But I want to highlight the gap in life expectancy, which again is in the bottom right corner, because again, as we see here, everyone's life expectancy has slowly improved since the 1960s in the United States. Black and white life expectancy has improved, and yet the gap between Black and white persists. So I think that that's incredibly important when we're thinking about the health outcomes of systems of racism and how health is impacted by systems of racism. Tremendously important. And just one last annotation to say that in the first 6 months of the COVID pandemic, what we saw was that Black people's life expectancy in the United States went down an additional 2.9 years. Whereas white life expectancy in the US went down about 1 year. And so this suggests that the gap in life expectancy between Blacks and whites is actually going to be the worst it's been in a very long time, in large part because of the inequities in outcomes and exposure to risk for Black people during the COVID pandemic. And in response to that, as well as in response to, I would say, massive growth in consciousness about systems of racism and structural violence and exclusion, there has been a response from the public health community across the United States that has really taken off, in particular, as you see in the bottom right graph, since the murder of George Floyd in May of 2020. You see that now, as of early 2021, we were at almost 200 resolutions and declarations across the country that racism is a public health crisis. And I want to give a huge shout out to Lillian Payne, who was the president of the Wisconsin Public Health Association in 2018, when they actually started this trend and published and passed a resolution declaring racism a public health crisis. And so what are the best practices in addition to raising consciousness through things like resolutions and declarations, which bring attention and visibility and often also resources to addressing racism as a public health crisis? Other best practices I want to highlight is the work of Dr. Chandra Ford around public health critical race praxis. And what this does is it applies critical race theory, which is a legal theory developed in the 1970s by law professors of color across the United States, and applies it to public health, recognizing that racism is so pervasive in the United States that science actually is not objective because of how thoroughly embedded systems of racism are in our thinking, in our policies, and in our systems in this country. And that in order to fight that, we have to generate knowledge from outside of the core knowledge base of public health, science, and medicine to be able to deconstruct systems of racism and how they are working and how they are preventing us from achieving global health equity. And finally, I just want to close with a thought towards the future, again, about both best practices for how we fight racism, as well as reimagining a future without racial inequity and racial injustice. And this is a study that colleagues and I published just a couple months ago. It's a study that looks at what would have happened in terms of the spread of COVID in Louisiana if we had if we had implemented reparations, reparations in this context being cash payments to Black American descendants of enslaved persons in the United States. If we had implemented reparations prior to the COVID pandemic, what our modeling and our study found was that COVID transmission in Louisiana, which was chosen because it's one of the most unequal social contexts in the country, and also had a huge burden of COVID infection and mortality. But we found that COVID transmission would have been between 30 and 68% lower in the state of Louisiana had reparations been implemented, because it would have decreased Black people's living in congregate settings. It would have decreased the number of Black folks who were frontline workers and therefore exposed to unfair risk. And it would have increased access just through, increased access to wealth and funds, increased access to personal protective equipment for Black people. So almost as good as a vaccine, and an incredibly important social intervention for us to consider going forward. Thanks so much, and I look forward to the Q&A.
Thank you, Michelle. Your presentation showing how system of racism is embedded in all what we live and do. And thank you very much, all the panelists, for your presentation, for sharing with us where racism comes from and how it is maintained, and also solutions. I know that our audience members have many questions, but before diving into the Q&A, I want to remind everyone that you can send your question through Zoom, Twitter, or Instagram, or in Facebook as well, using the hashtag Prof. Agnes. Ask Prof. Agnes. For all the questions that will not be answered by the panelists during the Q&A, they will answer them through social media but also only if the hashtag Ask Professor Agnes is there so that we can recognize them. Now it's time for the Q&A. And I'm going to start with you, Dr. Talia. Children who have suffered from racially charged violence may have a difficult time understanding the importance of reconciliation, and the legacy of trauma and loss continues to haunt many Aboriginal families until today. From your experience, Dr. Talia, what is the best way to challenge this common perception of racial difference that have been ingrained in their mind while living through assimilation and systematic removal? Thank you.
Thank you.
If you can give an insight in that.
A very complex question, and I'd like to just acknowledge that there are many First Nations scholars and practitioners and individuals who speak about this very eloquently and through lived experiences and through their understanding. I will present a response back in the work that I've done in the schools. I guess one of the schools that I undertook some research in had high numbers of Aboriginal and Torres Strait Islander children, and their experiences were diverse. And I think what's important to note is the real diversity for children, even from First Nations backgrounds, where some certainly were very active in responding and challenging peers and their understanding of challenging racialized jokes, of the narratives or the colonial storytelling their peers would present to them, as well as teachers, and challenging their teachers' response. But I think what's some of the complexity of this is that teachers and the executives often will talk about presenting race and reconciliation in a way that keeps everybody safe. So we will promote reconciliation and we'll celebrate First Nation cultures so that we don't go through a political process in the schools, or that we don't potentially acknowledge the trauma. But I think what's happening, certainly in the schools I was in, was the absence of focusing on or questioning whose safety are the teachers thinking about. Because again, when we don't give space and culturally safe spaces for children to explore this, then what we're doing is silencing it and continually privileging non-Indigenous cultures, particularly Western cultures.
Very interesting and very true. So you have to look at to who you give the space of safety.
That's right, and in in specific places, the need for very discrete, culturally safe locations within school environments.
Thank you, Talia. Bishop John, the next question is for you. Many people say that Rwanda chose to do what is right for us Rwandan, giving our context, and not dictate, as it were. Can you comment to this reflection? Especially Bishop John, when you have two theory, you have to stop talking about ethnicity because it's wrong and race, or you have to talk about it, but how to solve it? Thank you.
Well, thank you. Thank you very much, Professor Agnes. I think people say what's right on Rwandan choice. Rwanda and the Rwandese together under the leadership, the current leadership of Rwanda, the Rwandese people learned from their history. The history which depleted their dignity and it took their resources and confused their existence and depleted almost everything in Rwandan. It's time for Rwandan people, and it was time duly, to be able to know what now is best for them. From the contextual realities and experience, the Rwandese people chose to take upon themselves what is best for them, and to know which methodology to apply and the steps to take to get from where circumstances put them and go where they want to go. Rwandan people can no longer surrender to the waves of the world, but the Rwandan people need, as they relate to the rest of the world, to make sure that they become the masters of the destiny of the Rwandan people today and for the generations to come. And our dignity as Rwandese and our way of living and our constitution as it stands maybe is there for us and for our people, so that we know our rights cannot be defended by any other but us. And our destiny, therefore, will be driven by us. And it's not only for the people of Rwanda, it's my groan with humility. I wish all the Africans who suffered the way we did should take responsibility for themselves, and possibly not to be united as Rwandese only, but unite as Africans in order to be able to stand firm for what we want and be able to relate to others without being dependent upon them. And it's our joy and prayer. And through our unity, we get the energy for our shared economy and development. And to get our unity gives us the power for patriotic mission. And therefore, the Rwandese people need really to engage themselves to be responsible, accountable to the nation, to the rest of the world even, but not being dictated again, because we have had enough. Thank you so much.
Thank you, Bishop John. So I think you express really how to solve a problem that has been generated by the colonial, those who have colonized us, and coming from outside. Recover our ownership and don't let you dictate, and reflect yourself inside yourself without others, where we come from, why we did so, and where to go. Thank you. The next question is for you, Dr. Sylvia. Do you think that the representation we have of the Indian culture, after what you have shared with us a lot about the minorities, about who is governing, and about who is mistreated by racism and the caste system and the impact on health, but there is a lot of the Indian culture we have in other places of the out of India. Do you think, the question to summarize it is, do you think that the representation we have of the Indian culture outside in other countries match with reality?
Thank you, Professor Agnes. That's an important question. I think to a large extent, there's a misrepresentation of India to the outside world. And that is because it's predominantly people and communities that are from the oppressor communities that are outside in other parts of the world. And I think the international community often reinforces some of these misconceptions. And this is not only in theory, I think in terms of real life impact, it is very huge. So I think there is an idea that India is a land of like mysticism and yoga and vegetarianism and the milk and honey and so on and so forth. But just to take the example of vegetarianism, it's only about 20% of Indians who identify as vegetarian, and they come from an oppressor community mostly. And the idea of vegetarianism is very closely linked to purity. And people who consume meat, especially beef, people who consume beef are considered as polluted, untouchable, and there is very often discrimination that is being faced by these communities. And we see the impact of that in huge levels of malnutrition in India, where people who traditionally are used to eating animal foods, they're criminalized for it. And since the last few years, with the right-wing government enabling vigilante groups and mobs, there's been huge number of lynchings of poor men and from the Muslim and Dalit communities. The Dalit is what I said earlier, is the scheduled caste, or the communities that were originally the inhabitants of India, but now come under the oppressed scheduled caste communities. And the way the international, we have international academia, international research bodies, just taking the example of vegetarianism, they amplify this and they say India is a vegetarian country, India is good for the climate, India has plant-based foods, and they use it for a larger kind of propaganda, which is adversely affecting India. Like I put up in the slides initially, we have huge levels of malnutrition. We have anemia, which is the largest cause of maternal deaths in the country. We have stunting of almost 35% in children from these oppressed communities. So I think the international community has a very warped idea of India, and it really needs to see who it's getting its information from.
Yeah. Thank you for your comment on that. And what do you advise to get the right information about India? What do you advise?
So I think the international community, like I said, they should look at their source of information, especially researchers and academia. I think they need to look at the real life impact of some of these agenda that they're pushing. So for example, they want to have open up the markets for healthcare or for nutrition or for education. And in terms of who's going to access it, it's going to get completely skewed. It's the poorer children, the children from these oppressed communities who are going to fall out of all these systems. And also, I think it's important for the global community to understand the similarities between racism and casteism, and also to include it in the discussion. So we see a lot of oppressor caste Indians in, say, the US or in Europe, who show a lot of solidarity to the Black Lives Matter movement, but then they're completely silent on caste issues. You would never hear people from oppressor communities talking very vocally about Black Lives Matter, but they would not talk about their own discrimination and hierarchy within their own country. And very often these rich Indians send back money, and they economically enable a lot of these oppressive structures. They're very strong politically in the US and even in the UK, and some of the other countries. So I think looking at it from a political and economical perspective is also very important, because they have real life consequences on us. And one more point I want to mention is, like, I'm part of the campaign against racism, and there's been a lot of discussion about ideas of, reparation, representation, affirmative action. In India, we're still struggling with affirmative action. There's a lot of resistance to that. But, having these discussions across countries, sharing lessons, sharing solidarity. I think it makes a huge difference to people who otherwise, they have to repeat the same mistakes and they have to learn the lessons all over again. There's a sense of isolation. So I think this global communication is really important.
Totally agree. And it's important to recognize racism in all its form. Yeah. And assure that development goes through equity. Yeah. Thank you, Dr. Sylvia. Michelle, a question for you. Statistically, we have seen that Black Americans in the United States have poor health outcome compared to other ethnic groups. What can be done to ensure equitable healthcare for Black Americans? And especially from your experience, how can healthcare professionals incorporate racial equity in their day-to-day work? This is an important question for our students.
I absolutely agree. I think it's the $1 trillion question, and I appreciate it, and really also want to say how much I appreciate the comments from the other panelists. Dr. Sylvia and I work together already, but it's great to learn from the other panelists. This is a really powerful conversation, and I'm happy to be a part of it. And yeah, to your question, Professor Agnes, it's I think that is the question that many of us are working really, really hard to put forward really concrete and clear solutions towards. It is true in just about every indicator that you look at. Black folks in the US are doing worse than white folks. And this is not a new problem. It's not a new analysis. And as I showed in the chart in my brief presentation, unfortunately, the gap between Black and white in almost every indicator has not actually closed over the past 5 decades since the Civil Rights Movement in the United States. That's not to say that the Civil Rights Movement was not a deep and important and successful movement. It is to say that we have to be thinking differently going forward about how we can be more race explicit in our work and how we can be more direct about calling out racism, naming racism, as Dr. Jones says, and really being clear that the policies, the way that we distribute resources, the way that we value the lives of Black Americans, as well as Indigenous and other people of color, has to change. And we also have to recognize that change, even if we change overnight, because these systems have been in place for 400 years in the United States, it's going to take time to see the results. So to answer your question more directly, I think part of what we need to do in order to ensure that the outcomes of Black Americans in particular, whether it's health, education, jobs, poverty, the way that we can ensure that those outcomes improve is by, number one, actually naming racism and being explicit in our healthcare and other policies about increasing resources to Black communities specifically, and doing so in a way that corrects injustice. This is not something that's unfair to white people. This is something that actually states explicitly that we value the lives of Black people, and therefore when we see the trends in poverty, education, and health outcomes in Black communities, we're going to act to meet the needs and address the resource needs in Black communities specifically. I would say in the healthcare space, we have to recognize that health insurance alone, access to health insurance alone is not enough. And sometimes the conversation in the United States becomes reduced to only talking about health insurance and access to health care, even though that's an important part of improving health outcomes for Black folks. We have to also, of course, be talking about the social determinants of health. So the conditions in which Black people live, are raised, grow up, and thrive or don't thrive. So beyond just health insurance, we have to be also looking at housing, food security, access to education, and again, all the other poverty alleviating measures. But specifically in healthcare, where I work, what I would like to see us do is recognize that the trends that we've seen at our institutions, and I'm thinking specifically of some of the work we've been doing at Brigham and Women's Hospital, looking at heart failure and looking at the fact that Black and Latinx patients are systematically excluded from heart failure care, specialty heart failure care. Those are the kinds of things that are completely within the control of institutions, and institutions have to be held accountable and be responsible and responsive to communities of color who have been systematically excluded from specialty care and access to care in ways that create the very inequity you're talking about, where Black people have worse outcomes for heart failure. And yet, if they had systematic increased access to heart failure care, those outcomes, that gap would go away. And so again, I think it's access to resources, and it's being race explicit about how we do that.
Sorry, without tackling the social determinant of health, we cannot solve the problem of poor health outcome, and even start creating the necessary access to the Black community for appropriate care. So for creating the demand, but we need also to create the supply, and talking openly about what is going on. That many people are blind, but I have to say that love to be blind about it because they don't like to question their own privilege. And this is an important thing that we have to talk also about. You know, we die not necessarily because we are killed by our enemy, we know them, but we are killed by the silence of those who are our friends. Yeah. The following questions goes to our host, Tion. Tion, as you have noted in your opening remark, the gender and diversity audit has been incorporated into UJG to mainstream issues related to those two topics. As chair of this center, what does diversity mean for you?
Good question, Professor Agnes. For me, diversity is an opportunity. When talking about diversity, we raise issues of cultural diversity, gender diversity, religious, ethnic diversity, among others. This is an advantage. It helps to bring a range of perspectives, experiences, knowledge, and it's in general what we are striving to do at UGH. We have heard discussions about how race is a social construct, right? We can argue against this, but it is important to recognize that social constructs have created marginalization of certain groups based on their skin color, ethnicity, and other features. And these discriminations come from fear of diversity, fear of competition for power, resources, and so on, in my opinion. But if we can promote it as an opportunity, call for collaboration, and work on that, I think we can see less conflicts in the world. We see that is a problem across the globe right now. So let's, I feel it is an opportunity, and that we should work towards promoting it as such. Thank you, Professor Agnes.
Thank you, Tion. And for the students who are listening to us, they know what to expect. There is a question here in the Q&A asked by Paul. First of all, he starts by thanking the panel, and he asks, how can the concept of intersectionality, which problematize more macro, hegemonic concept of exclusion and bias, be better applied in public, international, and global health intervention? So it's for more than one speaker, and I'm going to start with you, Sylvia. Did you get the question? I repeat it.
Sorry, I did read the question and it's a little complicated for me, so I'll wait for the other panelists to answer.
Michelle?
Yeah, no, I think it's a great question. I think one thought that comes to mind immediately is that, you know, Kimberly Crenshaw, who's the legal professor who developed intersectionality as a concept and as a one of the tenets of critical race theory, she herself talks about the fact that sometimes she worries that intersectionality can be used to take our gaze away from racism instead of actually deepening our analysis of racism. And so I want to start just by saying that I think intersectionality and Professor Crenshaw's work really helps us to understand the ways that systems of oppression interlock and work together, both to create additional privilege for folks who have the identities of privilege, the intersecting identities of privilege, which would be, you know, elite status, high earning class or caste, male gender in particular, often Christian religion, and white racial status. So those intersecting identities can create compounding levels of privilege, but of course the opposite is also true. It can also create compounding, intersecting layers of oppression that is experienced differently than taking each of those identities independently. But I hope that we can use intersectionality to go deeper into racism, not take take us away from understanding how racism operates. And so then how do we apply that to, well, social epidemiologists have been applying this for decades, but how do we apply this to public health? How do we make our public health praxis and our interventions better using and understanding intersectionality? Well, I think it starts with understanding the health needs of the folks who have those intersecting identities. So it's not just looking at Black people, but it's looking at Black women, or Black people who are sexual minorities, or Black people specifically who are from oppressed classes, or who don't have class privilege. I also think it's looking at anti-Blackness in various communities. And so I guess I would say part of the way we operationalize intersectionality in public health is by choosing to focus our work, understanding the needs and priorities of the communities that have multiple identities that have been oppressed over history.
Thank you for this comprehensive answer, Dr. Michelle. Talia, do you have something to add?
I think that was an amazing response. I think what I'd probably add is that I guess that's very outward looking. So when we're looking at teaching, or when we're looking at research, or we're looking at those who are designing policies, who's actually designing it? And do we have the intersectionality and the input from a diverse, and I guess it goes back to Sion's question, do we have the diversity of those who are actually presenting, teaching, undertaking the research and designing the policies to reflect that intersectionality?
Yeah, that's true. So there is a question from Akiki here. Dr. Sylvia, it's directed to you. Thank you for the presentation talking about the India racialism scene. That is not enough heard from in Africa region regarding caste and how this leads to social determinants of that affect all areas of life. you mentioned education as one of the way to repair this. Tell us more about where this is happening and what are the early outcomes of it.
Thank you. I can't pass that question on to someone else. So actually in India, like I said, we have like the Dalit communities, and most of them depend on the public services. So whether it's education or food subsidies, or whether it's health, a lot of them depend on public facilities. And one can see there is a very systematic attempt to break down this. Like I think in the campaign against racism, there's a lot of talk about racism and capitalism colluding. And if one looks at in India with that lens, it's very tangible. So even if there are schools, you can see they're in such a state of disarray. There's a constant low budgeting. The teachers, there are not enough teachers, there's not enough funding. And this goes on even into higher education. And if you look at, I mean, I got the point about intersectionality, and that operates here because we see that like we always, even within the health system, if there's an incident of oppression or some harassment, or somebody is facing some kind of abuse, whether in the community or within the healthcare system, they always told that it happens to all of us, it happens to everyone. But I think it's important to understand incidents as opposed to structural factors. So in India, we have a whole structure that operates to keep people in oppression. So for example, if a Dalit woman or a Dalit girl is raped, and it's very common actually, there are a lot of instances of people from Dalit communities, women being raped and gang raped. And if you see it's them and their families on one side, and it's the entire structure, like whether it's media, whether it's the politicians, whether it's the health system, the judiciary, the police, civil society, it's an individual and a family versus a structure. And I think that uh, we need to have that clarity in defining experiences of incidents of abuse versus structural systems of abuse. So in education also, it's the same. It's multiple dimensions that come in. Uh, just to give a quick background, we have occupations which are called unclean occupations, which only the oppressed communities end up doing. So you have children from Dalit communities being asked to clean the toilets, being asked to sit separately, practices of untouchability. And this goes on even into higher education. So there are pockets. I mean, there are a lot of Dalit communities that have been educated, who've gone outside the country, who are economically well off, and a lot of them are now challenging this mainstream narrative of hierarchy. So yeah, education has its role, but it still has a long way to go.
Thank you for your answer, Dr. Sylvia. And that's true that education can also be another pretext for exploitation. And for the Dalit, it's an example of that. Bishop John, the next question is for you. Rwanda deliberately chooses to be united and reconciled. What can you say about the unity and reconciliation changes that have happened in the process of Rwandan people and nationality? You are on mute also. You make the same mistake I just did.
Thank
You are again on mute. Bishop John, you are again on mute. Yes.
Do you hear me now? Good.
Yes.
The Rwandese people, Professor, chose to be united and reconciliation as I said earlier on, reconciliation for us in Rwanda is the source of energy. It gives us the ability to get our talents together and give ourselves a sense of healing and a sense of development that we need to do together. We have been fragmented for a long time and have been exploited for a long time, and we have been manipulated for a long time. And in order to avoid that, we really need to be together in order to pour our resources and our energy in the same pool for development that we put into our plan and our strategies. And this, as I shared earlier on, not only heals our social fabric, it also gives us the dynamism to plan and execute and protect what we are developing. We know very well that the destiny that we share, the vision to engage the destiny that we share is for all of us. And I think you are aware that in Rwanda, in the whole of Africa, I think in most places in the world, Rwanda has had a high level promotion of gender. Rwanda is developed by all Rwandese, men and the women. Rwanda has gone all ahead in promoting the involvement of youth in issues, in political issues, economic issues, social issues of the nation. And the purpose is not only to prepare them for the work in the future, is to engage them now so that they know their responsibility and the importance of our unity. Both young men and women, adults need to work together for the whole. And the whole has a future and destiny, and therefore nobody should be excluded into the engagement, into the work, and which in other words, in the political world, they call it patriotism, but patriotism is for everybody. Rwanda has chosen through our unity and reconciliation to be able to establish, as you have been saying, reflected in the health of the people. Rwanda has established a policy of health for all, not only those who can, but every Rwandan has a policy, a health policy, insurance policy, to be able to create the policy for all in order for all to participate into the development and the security and the justice and the ownership of what we have as a nation and what we develop as a nation. So for us, unity is whole. Unity is the source from which we draw the energy for development and the understanding of who we are. And I think we are recapturing our old selves. Rwanda, as I said, shared one language, one culture, and one faith, which was dismantled with the time by the colonials, as I said, with the intent as established into the resolutions of Berlin, which was practiced on us, and which possibly we need to be aware of in order to establish what Rwanda is establishing. So I really thank you for asking this question. Unity is all for us and helps us to get into all we want to get at, because it's the source of energy. Thank you.
Thank you, Bishop John. There is here a question for all of you. Asked by a young professional, Shagun Tuli. What is the best approach to tackle racism if we spot it as a young professional? How do we identify and approach it if we see it in our work setting, sometimes in our superiors? Real life. So I'm going to start by you, Talia.
It's such an incredibly important question, and I think probably we've all faced this in different elements. I think, I mean, my advice to colleagues and to more junior staff is that it's actually not always safe to call it out directly, but there needs to be other ways to call it out, whether it's through providing more information about what racism is, providing examples that the approach that might be being mentioned or taken is going to impact from a racialized perspective. But I think, I mean, I don't know if I have the answer, the one answer. I think it changes each time. I think it is complex. I certainly, when I was doing research in the schools and on a daily basis, seeing everyday racism, if I was to call it out every single time, I probably would not have been allowed back in the school to undertake the research. And so it's around identifying ways to get the message out that will change the system, not just the individual as well. And so I hope there's some information there for you. You're on mute.
Sorry. Sion, thank you, Talia. Great answer. I want, Sion, what can you say about this question?
Well, like Talia said, I think we should not stay quiet. We should confront it when we can, whether we are at the receiving end or not. And we should also try to look at what exists in the communities that we work in, not only in our work environment. And maybe something we have started to do is doing a gender and diversity assessment, which I mentioned earlier, and some elements of like the overlapping issues, what we talked about, intersectionality and discrimination based not only based on race, gender, age, socioeconomic background, religion, and so on. These are things that we can explore. Yeah, we can do such studies, talk about it, create conversations around it. And we have started this conversation at UGHG, right? We had a town hall meeting on a range of topics, and one issue was race. So it is important to raise these discussions and explore what people are feeling about it. Thank you.
Thank you. Dr. Sylvia, what is your view about that? A young professional that experience or see racism and ask advice how to identify it and how to handle it, especially if it comes from superior.
So I think people, when they call out oppression or harassment, I think it's only when they do call it out that they realize the full impact of the pushback. And sometimes people are not prepared for that in any way, like mentally or physically or emotionally or economically. So I think being aware of the consequences, like going about it in an informed way, I think it's important. And I think it's very important to find allies who have some amount of power, and that's why it's also important to have representation in the power structures. And I think that would definitely help to push back on this, because like I said earlier, individuals or families against an entire structure, I think it's very unequal, and the power abuse can be huge and the impact can be huge. So people should understand the consequences, but definitely aspire to be in positions of power where you can challenge these structures.
Thank you, Dr. Sylvia. And you, Bishop John, what advice do you give to young professionals who experience that? You're on mute.
And I was muted. I think, Professor, thank you for letting me contribute to this. I think the advice I can actually give from experience is that whatever racial or discrimination or any attitude that is exploitive, that undermines somebody's dignity, ability. One is to expose what it is and also be able to know the effects of it on human beings and society, and also be able to resist it. It's not enough to talk about it. It's not only to expose it, but also need to be able to devise means to resist it and actually to fight it back. And we don't have to do it alone. We need to mobilize others to know the effects such things have on us and on our society. And the loss of an individual person in a society is a lot, because that individual person who is lost or lost the ability, the fullness of ability in society, is part of the loss of society. Therefore, we need to be able, by all means, know it, its effect, expose it, and resist it, and mobilize against it. Thank you so much.
Thank you, Bishop John. Michelle, half a minute to add on that, if you have something to add, because what Talia, Sion, Bishop John, and Sylvia have said are great. Do you have something to add on that?
I have very little to add. I couldn't agree more with what they said. And the only thing I'll say is that I couldn't agree more that it's not to be done alone. I think it's, this is, the response has to be from, groups of concerned individuals who have found, each other and organized together to really build so that no one feels like they are alone responding to either a specific incident of interpersonal racism, or to the structural institutional level. Either it has to be done. It's teamwork for sure.
Thank you. Great answer, all of you. Now there is here a request from one of the participants, Akiki. She asked this: could each panelist please summarize a personal dream concerning that topic? I give you 1 minute because we are almost over time. So can all of you summarize your dream about the problem? I start with you, Talia.
So my dream is that children are not the ones fighting this and challenging it and being the teachers that I see it, I attended Black Lives Matter protests. I can see it in classrooms where children are standing up and challenging narratives and teachers' positions, and they're doing it alone. So the previous question, and the impact on children. We talk about that racism isn't biological, and yet the impact, the physical and the mental toll that takes on children in order to do that and have the courage to do that and then live with that. We need to build the skills in the teachers to create the spaces that we can talk about race in safe ways for all children. And that would be my dream, that the children are not the ones who are putting this on the agenda.
Thank you. Michelle, what is your dream? 1 minute, because we no longer have the time. So
yeah. I have so many dreams. I have so many dreams, but specifically about this one, I think it's really self-determination and a resurgence in Pan-Africanism, but a new flavor of Pan-Africanism, one that certainly unifies the continent and the diaspora, but that is feminist, that is not, that is about disability justice rather than ableism, that is about inclusiveness for any and all sexual identities. So I think I would say a resurgence and a rebirth of Pan-Africanism and self-determination that takes us forward into the 21st century.
Thank you, Michelle. Sylvia, what is your dream? 1 minute.
So my dream is a world where diversity is valued and celebrated, and we acknowledge the rich traditions of different cultures and place it on an equal value at a global level. Give voices to people and not have like the same people for generations representing all our voices. That's my dream.
Thank you, Sylvia. Bishop John, what is your dream? 1 minute.
Thank you, Dr. Professor. My dream and grown actually is that the leadership of the world today, racism is no longer serving the world. Inequities and the suffering of the world needs to be tackled by leadership. And more so, coming back to the youth of the world should be the hope and the source to redeem what the global village will be in the near future. Thank you.
Thank you, Bishop John. And you, Sion, what is your dream?
Yeah, well, I dream of a peaceful world where people are not divided by ethnicity, race, gender, and do not feel threatened by others or do not threaten others and can coexist peacefully. That's my dream. And given the ongoing conflicts in my country right now, Ethiopia, this is top on my mind, peaceful coexistence.
Thank you, Sion. So we are reaching the end of our discussion, and thank you for all the speakers and the audience for this fascinating conversation. And thank you for using this platform to share our best to combat racial discrimination, stigmatization, and bias. Thank you to our host of the Center of Gender Equity. And if you want to connect with the center, you can email Sion or Twitter Sion or go to our web. As an university, equity is our driving force, and we have already incorporated a focus on the right of minorities in our holistic education and bring together experts and change makers who champion inclusion and awareness of discrimination and bias. This is needed now more than ever in this challenging time to support the most vulnerable. Our work, all the work of everybody should include protect and empowering of minorities. We had a brilliant insight during this event, and so I would like to extend my warm thanks to all of you. The webinar is recorded and it will be disseminated on the University of Global Health Equities channel shortly. With the help and the support of the panelists, we will answer all the questions that has been sent with the hashtag Ask Professor Agnes on Twitter, Instagram, and Facebook. You can follow the discussion there. All the questions will be answered without any exception. And we are going to close this session with again, and thank you. So I wish all of you a good afternoon, good morning, good evening, whatever place you are in the world. And I look forward to seeing all of you again in the upcoming UGLG webinar of next month for the Ask Professor Agnes series. Thank you, Talia. Thank you, Michelle. Thank you, Sylvia. Thank you, Bishop John. Thank you, Sion, for hosting us. Thank you, Sylvia, for this amazing discussion. And
thank you, Professor.
Thank you to you.
Thank you so much.
Thank you so much.
Thank you.